I don't know why it's on mute. I think they're still on mute.
Hello, good evening everyone. Welcome to the Royal Photographic Society and this evening's Combined Royal Colleges Lecture 2020. My name is Michael Pritchard. I'm the Director of Education and Public Affairs at the RPS, so on behalf of the Society. And it's my pleasure to introduce to you Dr. Afzal Ansari, who chairs the RPS's Medical Awards Committee and is also chair of our Medical Special Interest Group. Afzal, I'd like to hand over to you. Thank you.
Thank you, Michael. Good evening, ladies and gentlemen. I hope everybody can hear me. First of all, I would like to say that what Michael said, this lecture is for 2020, in fact, is for 2019. I'll explain in a minute why. I will introduce a speaker after a few words I speak about the awards. The Combined Royal College Medal Award was originally established by the Royal Photographic Society in 1958 in collaboration with the Royal College of Physicians of London, the Royal College of Surgeons of England, and the Royal College of Obstetricians and Gynecologists. And since 2015 by the Royal College of Psychiatrists and the Royal College of Ophthalmologists. In fact, we now have 5 Royal Colleges collaborating with the Royal Photographic Society for this award. This prestigious award is given for an outstanding contribution to the advancement and or application of medical photography or the wider field of medical imaging. The recipient of this award is expected to give a lecture a year after receiving the award at one of the 5 Royal Colleges in London. So Professor Reza is in fact the recipient of 2019 award. So therefore this lecture is for 2019 being given a year later. Anyone, member or non-member of the society, can nominate any person, whether member or non-member of the society of any nationality. And the closing date for the next nomination is 29th January 2021. To nominate, please visit www.rps.org/awards, where you can complete a nomination form. You should now have the web address in your chat box, I hope. Now, first and foremost, in my official capacity as the chair of the Combined Royal Colleges Medal Award Committee, I would like to congratulate Professor Razavi for being awarded the Combined Royal College Medal Award for 2019. Ladies and gentlemen, you may applaud. Ladies and gentlemen, to introduce Professor Razavi in full will take me longer than it would take him to deliver his lecture. Therefore, it would be wise of me to keep it brief. And I will do the brief introduction now. Professor Razavi holds senior research leadership positions at London's King's College, at London's Health Partners, and as a consultant cardiologist at Guy's and St. Thomas's NHS Foundation Trust. He led the development at King's School of Biomedical Engineering and Imaging Sciences in the 10 years transformation from 20 to over 400 active researchers. His research interest is in medical imaging and biomedical engineering, related to cardiovascular disease, and he has been awarded substantial grant income working with industry to deliver technologies that move into clinical products. One key area of focus is cardiac magnetic resonance imaging in relation to congenital heart disease, electrophysiology, and heart failure. Professor Razavi is actively involved in both national and international bodies in the field of cardiovascular imaging, including developing the curriculum for training of doctors in this area, alongside organizing national and international meetings. He is past chair of the British Society for Cardiovascular Magnetic Resonance Imaging. Professor Razavi, I would now like to invite you to deliver your lecture on fixing the broken heart. Over to you. Ladies and gentlemen, again, you may clap.
Thank you very much. Thank you, Dr. Ansari, and a big thank you to the Royal Photographic Society and the Medical Committee. I hope you can all see my slides now, my first slide. Or do I have to share my screen again? Do I? Perhaps I do, so I'll just do that, just to make sure that you can see it. Let's see if this works. Yeah, hopefully this does.
That's perfect. Thank you, Professor.
Okay, brilliant. Well, it's a real honor and a pleasure to get this opportunity to give this lecture. And thank you so much again to everyone for Royal Photographic Society and also to Michael and Joe who've organized it. And, you know, thank you for that. You know, we have 45 minutes and I will therefore focus on just 3 areas. You'll be glad to know, otherwise we'll be going on for a bit longer. But I think you will get a flavor, hopefully, of my sort of journey in medical imaging and heart disease in these 3 areas. I could have chosen a number of different areas, but hopefully this will give you a little flavor. And I'm going to start by showing a photograph because, of course, this is the Royal Photographic Society. Oops, going forward, let's see. This is a photograph of Werner Forssmann, taken in 1929. And you can see he actually has a catheter put through his cubicle fossa, right through going into his heart. This was the first cardiac catheterization procedure. And he then, having done this, walked down the corridor, down some stairs to what was equivalent to the radiology department, and got a photograph done of his, an X-ray done of his chest. And here's the X-ray. And you can see here is the catheter that he passed. It's nearly 1 meter long, going through his left arm, right through down here into his right atrium. Now, Werner Forssmann got the Nobel Prize for this in 1956. But at the time, actually, he was hugely ostracized and criticized and ridiculed. And in fact, so much so that he actually gave up on research. And it was only many, many years later that people realized the great sort of leap that he took forward by doing this, and in fact doing it on himself. It's a very brave thing to do. He was a young surgical doctor in a rural, provincial German hospital. If you look at this X-ray of a catheter, then try to keep this in mind. I'm just going to again move forward a little bit to 1994, April 1994. Now, you might all remember that was the time when Nelson Mandela came out of prison and was running to be the president of South Africa. The Eurotunnel was opened and Eurostar was starting to run. And it was also the time when I arrived as a young doctor at Guy's Hospital. This is a picture of Guy's Tower. I used to work on the 11th, 12th, and also first and second floors, because that's we were all split in different places. And as a young doctor working in cardiology, in pediatric cardiology, in fact, actually, by the way, this is me, Guy's Tower now, and of course changed a little bit. It looks a little, it's had a facelift, and of course the Shard's next to it. And all this time, I've been in the same place. Actually, it's a very long time to be in the same place, both at the Guy's campus and the St. Thomas's campus. And what I'm going to talk to you about, really, I want to start from that time when I first arrived. So I arrived and I was doing cardiology, and of course, like Forsman, there I was doing cardiac catheter procedures. And this is a picture of one of the procedures I was doing. And if you look at it, it doesn't look very different to the one he did. It is this catheter, and here you can see a silhouette of the heart. But I had to learn, and I had fantastic teachers, as you manipulate a catheter and a guide wire and devices inside the heart and blood vessels, that you don't see those structures. I mean, sometimes we would inject dye and you can briefly see them in a flash, but you basically don't see them. You had to, in your head, sort of imagine them. And of course, in patients with congenital heart disease, they have scrambled hearts. And so sometimes the imagination wasn't good enough to understand where things went. And it was trial and error, push here, pull there, twist there, trying to get these catheters to go to where they were. And that was a real challenge. I then started getting involved in research, and I built a research program around MRI. And this is a slide from a presentation I gave back in 1998. I remember it was one of my first international sort of conference. It was very exciting for me to go. It was the 10th World Congress in MRI Angiography. And what had happened was technology had basically been making rapid progress. And MRI had gone from being able to take a single slice image, which we've been doing initially for a number of years, to be able to take multiple slices, so in effect a 3D volume, quickly enough to be able to image the heart and the blood vessels by giving some contrast agent. So, you know, this is a different contrast agent, gadolinium. And this was one of the pictures. I remember this lady, actually, this was a lady in her 30s who came into hospital short of breath. And we did some echo scans. And in the end, we couldn't really exactly work out what we do. So she was referred to me to do an MRI. And we tried this new method on her. It's one of the early patients we tried it on. And you can see here, we're looking from the back of the heart. This is the aorta, the main blood vessel that leaves the heart. And if we're looking at the back, this is coming down next to the spine. You can see the arteries to the lungs. These are the pulmonary arteries. And then you can see the big veins from the lungs, the pulmonary veins coming to this, which is the left atrium. And in 3D, you can see beautifully the veins coming here on the left-hand side. We're looking from the back. But the ones on the right are not coming into the left atrium. And here you can see it actually coming down into the right atrium, where it connects to the inferior vena cava. And I don't know if you can imagine this, but for years, when people used to see this on an X-ray, they called this a scimitar. It does look a little like a scimitar, doesn't it? So this is called scimitar syndrome, and this because of this when you see it on an X-ray. But of course, when we were able to see it in beautiful 3 dimensions, it was fantastic. You could completely see everything that's going on and help the surgeon then, who had to replumb these veins back into that to know exactly what to do and where to go. So this was a really big step in progress. And I'm not going to really talk about this, but going to talk about the catheter procedures. So that was what we were seeing. And I suppose what I really thought would be brilliant to see was the 3D anatomy in its full glory, as well as the catheter. And that's where we started a real program. But to get there, we had to do a number of things. And one of the really major steps was being able to have a cardiac catheterization laboratory, which not just had the X-ray, and here it is, but also an MRI scanner in it. And this was the first clinical cardiac catheterization laboratory that had an MRI system in it. There had been a few preclinical animal systems before this. And we worked closely with Philips to set this up. It was a world first. And we set that up at Guy's Hospital I remember actually where we put it was the cath lab where I first learned how to do catheterization all those years ago. And this was back in early 2000. And of course, the next step was to combine those X-ray images, which come from this X-ray tube, fluoroscopy tube, with the MRI images. And we had to do that and do it in real time, track both the X-ray and the table, and of course then register the images, because these two things, the table could move with the patient on it and the X-ray tube could move. And we used optical tracking for this. And this was basically optical cameras which tracked these tiny points on the tube and on the table. And so we were able to combine MRI images in 3D, the X-ray fluoroscopy images, and build 3D representations and do that in real time. And in this case, the catheters are to do an electrophysiology procedure. So this is a balloon catheter with multiple electrodes on it that can measure the electrical activation inside the heart. The other electrodes also can measure it. And here then you see for the first time, this is the right ventricle, pulmonary artery. The patient that we were worried had a focus of electrical abnormal activity there, causing an arrhythmia. We could actually see the three-dimensional shape of the heart and the electrical activation inside the heart. So both anatomy and electricity. And this actually led to us a whole strong program of computational modeling to be able to simulate in silico how the heart works, both mechanically and electrically. But I'm not going to talk about any of that in this talk either. But this was our first step of being able to really combine and help people doing interventional procedures, give them this additional information. And of course, the next step was to do this not in an XMR, because there were very few of those where we had MR and X-ray combined, but actually do it in a standard catheterization laboratory like this. And again, we worked with Philips to combine the data from fluoroscopy, the MRI information that could be acquired beforehand, and the electrical information into a system that could work in a standard cath lab. And this was a really important step. We built the first electroanatomical mapping systems and were able to then try them on patients. And this was patient, for example, who had another arrhythmia called atrial fibrillation. And they basically, we were able to map the electrical activation in 3D onto the shape of their heart and be able to see the anatomy of the catheter were manipulated. And we were then able to do even more. We were able to image the thin wall of the atrium in these patients and be able to see if there was scarring. So for example, in a patient like this, where we had ablated them once and it had failed, and we were bringing them back again, we were able to see where we had previously ablated by again giving gadolinium, and this lit up inside the heart where it accumulated, where we had burnt the heart before, and you can see the scarring. And we were then able to relate the electrical signal from the catheter. In this case, the catheter is somewhere where there is no scarring. Green and yellow is no scarring, red is scarring. And we see a high signal, 1.4 millivolts. And yet, if we went to where we normally isolate the arrhythmia for atrial fibrillation, which is around the pulmonary veins, and we were able to put the catheter there, you could see the signal went down right to 0.1 millivolt where there was the scar. So we were able to relate not just anatomy and electricity, but also basically the substrate, the pathophysiological substrate, which is in the wall of the heart, relate them all together. And this, again, is a pretty big step to being able to understand the disease and be able to treat it better. And we made progress from there to actually guide these ablation procedures using this anatomical information, and worked with Philips to, in fact, make this into a product. It's called the EP Navigator. And in fact, Philips commercialized this in 2008, and over 400 units were sold, and it's probably many more now. This is quite old data. But the point was that we started a journey where we had an idea, we used technology to develop methods, worked with industry, and eventually it ended up being something that could be used widely across many, many, many hospitals around the world. We extended now, this time working with Siemens, another one of the major imaging companies, to extend this to work for cardiac resynchronization therapy. So what's that, you may ask? Well, it's a treatment using a pacemaker for patients with heart failure. So patients with heart failure, some of them can have an asynchronous heart. The heart is baggy and it is discoordinated when it contracts. And one way of treating them, probably the best treatment for them, is to put pacemakers either side of the heart and synchronize, electrically synchronize that contraction, and then they can improve. Now, the problem is that it doesn't work in everybody. In a lot of patients, it doesn't work. And the reason it doesn't work is if, for example, that lead goes into an area of scar, and we're doing this all under fluoroscopy, so you don't see the scar. But on the MRI, we can see the scar. Here's the scar. The other point we need, because we can see the motion, we want to put the electrical lead where it's most asynchronous. And again, we see the motion on MRI. So we combined all this information to be able to project that on the fluoroscopy images so that and this is my colleague, Professor Aldo Rinaldi, who puts these pacemakers in, these cardiac resynchronization therapy systems in, being able to guide them to the right place. And actually, we're now with Siemens doing a 5-site multi-center clinical trial of this technology. And we also developed similar technology, again with Siemens, for congenital heart disease, for when we are putting in valves and other things for congenital interventions. Again, that's now up to having multi-site clinical testing. So that was getting MRI information and putting it into the X-ray cath lab. So how about actually moving and doing these procedures completely under MRI? And again, we were the first to do these in patients. And this is me at the MR scanner going back in 2002, so old images, showing, moving a catheter, which in this case you can see as a black ball. And instead of course, before you were able to see the line of the catheter, now I can only see the tip, but I can see all the heart structures. I can see the blood vessels. We made all of these things ourselves. We made pedals that control the MR scanner. So, and this was MR scanning very fast, 10 frames a second, being able to move the images up and down to follow the catheter. And here you can see the catheter now then coming round. This is a congenital patient with quite complex anatomy, being able to guide it to where we needed to go by being able to see where to go. So, solving that problem that we had all those years ago. And of course, that was hard to see, but here's more later work we've been doing where you can actually see this catheter much more clearly by using fancy MR physics, working with engineers, and also in this case, actually using gadolinium rather than air or CO2, which was in the previous case. We can now much more clearly see where the tip of the catheter is and how we guide it through the heart structures to be able to get it to the right place. Also guide wires, so working with companies, again, we developed these first guide wires ourselves, working with some German engineering laboratories, and then since then moving on, working with companies who've made these into clinical products. And the guide wires look like black dots, very different to what we saw under X-ray. But again, we can see the guide wires moving through the heart and blood vessels. So we started a clinical program. It's in the, under the NHS. It's been now happening in a number of hospitals. And this was data from back 2015, where we looked at our experience of over 10 years, where we basically the rare conditions, congenital heart disease, but we'd already done 220 studies in nearly 200 patients. And these catheter procedures are often needed to plan a major operation or a major intervention. And in 151 of those patients, they'd gone on to have those interventions successfully with good outcomes in every one. So it was great to be able to move a technology where we're now doing cardiac catheter procedures inside the MR scanner without the X-ray radiation, which is particularly not good for the children, and being able to then use that additional information, to lead to successful treatments. But the next step was actually, can we do the treatments inside the MR scanner? So not just the diagnostic catheterizations, but the intervention. And by the way, actually, many of the hospitals who've picked this up are also in the US, and this is an example of work from the NIH in Bethesda, where they're also doing these procedures. So here is one of our examples of intervention. We developed back in 2010. You can see the guide wire here now. And this is the heart, the right ventricle, this is the pulmonary valve. So now I'm going to past a balloon catheter to go and blow that up. Here's the balloon. I can see where it goes right through the heart, across the pulmonary valve, and opening up the narrow pulmonary valve. And again, we were showing that interventions were possible. And the next step in the horizon was, can we actually do the ablation of arrhythmias inside the MR scanner? So again, working for a number of years in preclinical models to build the technology. And here it is when we actually started doing these in patients. So you're now seeing a live procedure. We have different screens. This screen shows the electrocardiogram from inside the heart. And we're able to make measurements to see each point within the heart that we're actually looking at. And you can see on this screen, we're looking at the heart and we're live moving our catheter inside the MR scan inside the heart and making electrical measurements and building color maps of those measurements to show us the substrate, the abnormality, the electrical abnormality. And here it is just showing you what we call a local activation map, an isochrone map. So with one of the catheters, this one, the coronary sinus, we're pacing, and with the other, we're mapping how long it takes that pacing signal to get to each of the different points in the heart to build an electrical map, a conduction map of the heart. And these were patients with atrial flutter, which was the first group of patients we started doing these ablation procedures in. And we were able to then, once we've worked out where we needed to go, and in this case, so atrial flutter, we're going the isthmus, which is the point between the tricuspid valve here and going down to the IVC. And you know, normally you will not be able to see any of the anatomy. And here we are seeing it in real time. This is our catheter. And we were able to go ahead and ablate and actually plan where we were going to ablate first, and then place the ablation lesions one by one along where we needed to go, all inside the MR scanner. So this is really the first time that we're using active catheters that are seen in 3D, mapping inside the heart and ablating inside the heart. And of course, once we've done it, we were able to pace and show that we have caused a line of block because the pacing signal is blocked here. You see the color, this is early activation, and then suddenly becomes dark blues, late activation, because there's a line of block. So successful procedure. And we were also able to, and this has been really important, visualize the lesion that we have made. Again, using MRI during the procedure, at the end of the procedure, being able to see here using T2 imaging, edema that was caused by, and actually we didn't realize how much edema we actually caused because before that we were never able to see these, but that is caused by the ablation procedure. You know, basically when we give RF energy, heat energy to cause the ablation, to cause the burn inside the heart to treat arrhythmia, the wall of the heart becomes edematous and thickened. And using data enhancement imaging, gadolinium imaging, we were able to see areas of high signal, which happens over time, initially low signal to high signal. And in fact, we've now moved on to using thermometry. Again, I haven't got time to talk to you about that, but particularly for the left ventricle, using thermometry, where we measure in real time the temperature as we give the RF ablation and being able to tell whether we've made a full lesion or one which might be only temporary and go, you know, once the edema settles, recur. And again, these technologies, because we worked with companies, worked with Philips and with Siemens, are being made into prototypes, and I hope very soon into products. In fact, I think the Siemens one is on its way within a year or so to becoming an actual product. And actually, as a prototype, it's now extended beyond our laboratory to a number of other sites, both the Philips and Siemens ones. So it's been great. We've been working with these companies for many, many years, helping build these technologies into prototypes and products. Okay, the second part of my talk, I suppose there's going to be 3 bits, so we'll get through this bit. This is actually a picture of my daughter, one of our 4 children, Poppy, and it came out because the work we're doing, and next I'm going to talk to you about, which is antenatal detection of congenital heart disease, came about in large part actually because Poppy was born with a congenital heart problem, but it wasn't antenatally diagnosed. So many, actually probably all children in the womb around 20 weeks get a scan. And this is the sort of scan they get, an ultrasound scan. And the sonographers who are great, they look at all the different bits of the body, including the heart. And of course, Poppy had one of those scans. But Poppy was like more than half of the children with congenital problems, complex problems, where the abnormality was missed, wasn't picked up, not because of a fault of the sonographer, because these are complex problems and they're hard to see. If you go to a specialist, fetal cardiologist, pediatric cardiologist, they can see them. But our sonographers who are doing 700,000 babies a year, it's hard for them to pick them up. And it's variable. Some parts of the country, the pickup rate is only 10 or 20%. So I managed to get some funding, and we've set up a major program, and actually the website there, if you're interested to go and look it up, called iFind, where we're developing the technology, including using AI, working with many engineering, computer science colleagues. I should particularly mention my colleague Joe Haynor, Professor Joe Haynor, who leads all the technical developments in improving this technology and addressing this problem, improving ultrasound so that these congenital problems can be picked up. And we already have a very good prototype and started clinical testing, which basically uses AI to help the sonographers do better. But I'm not going to talk about that either. What I'm going to talk about is MRI, because at the sort of part of this program, we also said, what about MRI? Can we do better with patients whom we know in the womb, in the fetus, where they have a congenital heart problems? And the reason for that was, look, this after they're born, and this is bread and butter work that we do, we can get beautiful images of the baby and the children's hearts. In 3D, we can see all the anatomy of the heart and the vessels. We can see the heart function and motion, and we can see the blood flow in the heart, even in 3D or even 4D, because this is 3 dimensions, but also through time. So that's the 4th dimension. But could we do this in the fetus, where the heart is the size of your thumb in a 24-week fetus? That's small. Can we use MRI technology to do that? Well, again, there's a big issue there. So here's a little fetus inside the womb at around that age. When we do MRI, I'm sure many of you would have had MRI scans, and like the beautiful picture that I showed you, we get people to hold absolutely still. If they're children, babies, we give them even an anesthetic to keep them still. But of course, we can't get this fetus to hold still. It's moving around the whole time. And so that makes it doubly hard. Not only are we looking to scan something very small, but something which is moving about. So this is, again, as I said, mentioned the great work Joe and many colleagues have done to convert these very motion corrupted images, which you can't really tell what's going on because the baby is moving, into these beautiful motion corrected images using sliced volume reconstruction. You can beautifully see, for example, here's the aorta in the fetus, the big blood vessel that came out of the heart. And of course, if you put all the slices together, because we can do this in 3D in MRI, you can see beautifully 3D picture. This is of a fetus, a tiny fetus. And here you see the abnormality. There's 2 arches instead of 1. It's called the double aortic arch. And here's the trachea dividing. This is the breathing tube being compressed by these 2 arches. And we can already see this in the fetus beautifully in 3D. Here's another example. Do you remember I mentioned scimitar? Well, here's a scimitar in a fetus, a tiny fetus in 3D. So the yellow are the pulmonary veins. This one is coming normally back to the left atrium. And here is the abnormal one coming through to the IVC right atrial junction. It's incredible. And here is another example. So complex problem that it's very hard to see without in fetal life, even postnatal life really, unless you do 3D imaging. And we were able to see, for example, the pulmonary arteries, the arteries to the lungs. In this case, they're not connected to the heart. It's called pulmonary atresia, coming off the blood vessels that come off the aorta, one from the underside, one from this branch here. And actually in this baby, as soon as it was born, we took it and did a 3D CT scan, high resolution scan, and you can see the images look the same. We're able to see the same. And in fact, we have now set this up as a clinical service at St. Thomas's at the Evelina Children's Hospital, and we get referrals from around the country. And so now fetal cardiologists, if they have a complex problem, they send them to us and we can produce these beautiful 3D images and help with the diagnosis and help counsel the parents, tell them what's going to happen when the baby is born and what operation is needed. But of course, the next step was, can we see what's going on inside the heart? Here, you can see an ultrasound image, the two ventricles, the two pumping chambers, and actually there's a VSD there. Now, if you're an expert, you can tell. But by being able to do these MR scans, again, using technology that can correct all of the motion, we can see it in 3D. And we can get multiple views of the heart and be able to see that hole in the heart, that VSD. But let me just put all of this together for you. And here it is. This is a fetal heart, that tiny heart I was telling you, the size of your thumb, beating away in 4D. You can see the two pumping chambers, big blood vessel leaving the heart. And here is the VSD. This is incredible, really. I never imagined that in these few years we would make such huge advances to be able to see the beating fetal heart in 3 dimensions, in 4 dimensions. But not only this, we could even measure blood flow inside the fetus. Now, there is an MR method called phase contrast to measure blood flow. And we can put a slice across someone who's very, very still. And after a few minutes, we get blood flow in one vessel. But again, we have this problem of the fetus moving around. So if the fetus was completely still, we could see blood vessel in this aorta, the big blood vessel. But even if they move a little bit, it's all blurry and the numbers don't add up. So we have to keep repeating and repeating. Well, again, Joe and colleagues have come up with amazing technology. Now we can measure blood flow, and don't forget blood flow is in 3 directions. And we have it in 3D and with time. So I've called it 4D fetal blood flow, but some people might call this 7D in the fetal heart. And this is an amazing step because now, by having this information, again, using this sort of motion correction technology, we can measure blood flow at any of the blood vessels inside the fetus. And here, with the sort of representation, you can imagine not just in the aorta, but pulmonary artery, the SVC, all of the, artery getting to lungs, and be able to really dissect out the complex anatomy, but not only the anatomy, the complex physiology of the fetus, both in healthy, but particularly in disease. Really understand what's going on for the first time clearly in congenital heart disease inside the womb. And this is all the different blood flow curves that we get in all the major vessels. So we're moving to a comprehensive fetal cardiovascular MRI scan that combines 3D anatomy, motion inside the heart and the structure inside the heart, being able to see the volumes inside each of the chambers at each point in the cardiac cycle and the blood flow. Really an enormous step forward from the time where poor Poppy was born with her problems. And I'm glad to say Poppy is absolutely fine now, but it's something that children like Poppy who are born now can benefit from. My last bit of my talk is around artificial intelligence and the use of that in cardiac imaging, because we've talked about MRI of a single person. But if you want to apply MRI to a population, if we want to start not looking at patients with severe disease, but looking at patients much earlier with pre-symptomatic disease, where we want to screen and understand problems, then basically we're having to look at large numbers. And the only way to do that is using artificial intelligence. Now, when I see a patient clinic, or this doctor is seeing them, or a nurse sees them, we of course use our experience. You use the imaging data, we use the electronic record, the history, but we use our experience. And I suppose AI in a way is there to help us to work right to the top of our license, to be able to basically in effect have the experience of others brought to us to help us make the best decisions. But as a first step, it's about understanding those images. So again, this is work of many colleagues. I've got the names here at the bottom, but so Andy King is the engineering colleague, computer science colleague who works with me on this project, where we are segmenting not only the shape of the heart, but its motion, but not just one chamber, but all of the chambers automatically, robustly, using deep learning algorithms, machine learning algorithms. Now, of course, there are many machine learning algorithms out there. And if you have high quality images, they can train on them and work. But the problem with real life is that you don't get that. And you can often in the acquisition process have quality issues. And of course, because of that, often these algorithms don't work, don't learn very well because some of the data is not high quality, but also when it comes to applying them, don't work very well. So what the big step that we've taken in this is being able to identify when things aren't quite right. So here is what we call a 4-chamber view. See the 4 chambers of the heart. But here the planning is just off slightly, and you can see a bit of the outflow tract from the left ventricle. So that would confuse the algorithm if you learn from it. And here, for example, is a short axis view, it's a slice across the heart. And you can see here an example where there's blurring and motion artifact, because again, with the problem with the acquisition. And so what we have developed is a pipeline that allows the AI to automatically identify and reject images which are not right. And not only that, but by automatically segmenting all the chambers and working out the volumes and the motion, look at those volume curves and see if they're not physiological, and again, be able to reject them. By doing this, you can get much higher accuracy and being able to get, up to percentages that we're not being able to get up to this point. So here, sensitivity to detecting errors of 95% in terms of volumes and 93% in terms of strain. We've used this pipeline to look at a great resource we have in the UK, which is the UK Biobank, where many thousands and thousands of volunteers have had these MRI scans. And we've been able to use that to train our algorithms, and not only be able to then get the measurements that if I'm doing a manual measurement, I can do by measuring the volumes of the heart in systole and diastole and work out what the ejection fraction is, but much more sensitive, better measurements that are specific to the contractile phase of the heart, systole, and the relaxation phase of the heart, diastole. These much more sensitive measures require you to draw lots of lines over lots of points of the cardiac cycle. They're hugely time consuming, and you couldn't really do them manually. So they're not done. By being able to use AI, we're able to do them, but not just in one person, but in thousands and thousands of people. So these things like peak filling rate and strain rates allow us to be very sensitive about abnormalities. Now, of course, you could say UK Biobank is in effect a good training set for us, but now we've been able to move this technology and apply it to patients with disease, taking a big number of data sets in our hospital, about 20,000 clinical cases, and also collaborating with colleagues in the US where we've got another 10,000 clinical cases. And building models then that don't only work on one MR scanner in a very standardized way, but can work on any MR scanner, on any field strength, on any patient. And we do that by building these multiple models and then combining them to be able to have this smart network that allows us robust results. And here's an example of a patient with heart failure. You can see this left ventricle is very dilated, and we yet still be able to accurately segment it and look at the motion and at the volumes. So just coming towards the end of the talk now, giving you a little bit of a flavor of the sort of thing that you can get by using this type of technology. Here is looking at the UK Biobank data and looking at a sensitive systolic, so that's the contractile phase measure called peak ejection rate, and a diastolic relaxation measure called peak filling rate, looking at 12,500 healthy subjects. But amongst them, also 400 plus diabetic people who are otherwise healthy, but they just have diabetes. Now, if you normally looked at a heart, and MRI is the most sensitive way of looking at a heart, you would not be able to tell if someone's got diabetes unless the diabetes has progressed and they were at an end stage of causing them to have, for example, a heart attack or heart failure right at the end stage. But normally, if somebody's just got diabetes and they're being managed successfully, their heart looks normal. But looking at these sensitive measures, okay, in systole, during contraction, the heart is normal. I mean, the blue here is the diabetics. There's more of a spread because they're less in number. The red here is those without diabetes. I mean, one point to look at here, and this is the age, from 40 to 80. Firstly, when you look at this peak ejection rate, we can see all of us, as we get older, our hearts, performance in terms of systolic performance and diastolic performance gets worse with age. And although there's a spread, so some people could be a bit young for their age and some people a bit older for their age, this continues progressively. We're going downhill, I'm afraid, ladies and gentlemen. When you compare the diabetics, you can see that there is, in systole, really no difference. But and this is the blues, it overlaps with the red normals. But in diastole, there's complete separation. Every person who had diabetes, if you looked at them with the age-matched person who didn't, we can tell they had a reduced peak filling rate. And this sensitive biomarkers, which we haven't been able to use up to now before, will allow us to look at disease before it's progressed, before we have symptoms, and be able to help. And we've done the same from all the other risk factors like smoking, hypertension, many others, and can see the differences and be able to see where that is affecting the heart. And of course, hopefully feed that back to patients before they've got progressive disease, which is very difficult to address, to change and manage those risk factors to try to slow this progression into symptomatic disease. So AI can be a very, very powerful tool for us to help address this. So, to conclude, innovations in MR and multimodal imaging are transforming the care of patients. And actually, in my sort of career, when I was a young junior doctor, arrived at Guy's, at a junior cardiologist, to now, there's been enormous progress, and I've tried to show you a little bit of that enormous progress. And the way we're managing and treating our patients is being transformed by the use of technology. And I've given you 3 examples, how we've been using it to guide cardiovascular interventional procedures, how to be able to image the fetus, and of course, how we can use it with AI to apply it to populations and be able to pick up very early pre-symptomatic disease. And I suppose I just want to finally say a few key ingredients for my personal journey, getting this. It's been a real honor getting the Combined Royal College Medal. So what's been the secret of success? Well, there are 3 main things for me. One has been focusing on the problems that matter to patients. And of course, one of those patients were my own daughter, but also matters to the NHS because the cost of care is going up all the time. And these technologies can help reduce the cost of care, particularly the AI technologies, and take out bits of care that we provide at the moment where lots of time is spent but not much productivity is produced. AI can really help us with that, and we can provide better care, hopefully at lower cost. The other key point is multidisciplinarity. None of this would have happened without the work of fantastic engineers, physicists, and computer scientists working with us clinicians, and many young clinicians as well who work in our teams, in single groups, where we get not only the translation of the advances into the clinic, but more importantly even, it's the reverse translation, getting people to focus on the problems that really matter and all working together and having that fast loop going around addressing those problems. And the final point to make is, and you've seen that in many examples in my presentation, if we want to have big impact as researchers, then we have to work closely with industry because we don't make scanners and software. We need to work with companies who can take our research and put it into products that can then be widely used across the NHS. And that's not just big companies. We have to make a lot of small companies here in the UK. And we're working hard on that. And many of them in our AI center at the moment are small companies that we're hoping will become big companies in the future, working with the hospitals and the university to really progress and develop. My final slide is an acknowledgement and a huge thank you. All this work is done by a large group of people. I'm often there just maybe doing a bit of coordinating and cheering people up to do the great work they do. So a huge thank you to all many, many, many people. And I did it just in these 3 areas, and I'm probably missing lots. But of course, We work in many, many other areas as well, which I haven't covered today. So an enormous thank you to all the people who do all the hard work. And thank you to all for listening. I think we now have some time for questions.
We do. Thank you, Professor. That was fantastic. And as someone that isn't a clinician or involved in the medical world, it was really, really interesting and just so fascinating to see inside bodies and inside real people. So thank you for sharing that with us. Before Afzal concludes the evening, we're happy to take questions from anyone in our audience, and I've already had a couple of questions come to me directly, so I'll perhaps start with those, and if other people would like to ask questions, please drop them into the Zoom chat or raise your virtual hand, and we'll unmute you so that you can ask the question in person if you'd like to. So the first question I've got, you spoke a lot about the changes that happened between the 1990s and today, and it's probably a slightly unfair question, but how do you see MRI technology taking you forward over the next 10 or 15 years? Because it's science fiction already, and it seems like the world is just ready to see where this is going.
No, absolutely. It's a great question, actually. And I have a couple of answers, because we are also, I mean, I didn't talk about these, but we're working on the next points in this technology. And one I'll talk about particularly because we're getting one of the world's very first scanners in this space in the next 2-3 months, actually, into coming to us, working again with an industry partner, is MRI that can be done anywhere. Can you, at the moment, to have an MRI scanner, you have to come to a hospital in the UK particularly, because they're expensive, big machines that are hard to sight. You have to put an RF cage around them. They have to have a quench pipe. It often costs as much to install them as to buy the system in the first place. Using AI technology, we can now build much, much cheaper, simpler systems with lower field strengths that can produce beautiful images like the ones I've shown you, have bigger balls so people don't get claustrophobic. And basically, you don't have to try so hard and have so much hardware to get the images, because AI can help you make them like the images from the much higher, better scanners. So these low field systems will be easy to sight. You could, you don't have to worry about, at the moment, MRI, you have to get rid of all your metals and really worry about safety. Those are much less worrisome. They could, and I think they will become ubiquitous. You'll be able to have them in, most GP surgeries and most, even supermarkets. You can imagine people just dropping in, because if we want to have this idea that I was showing when we showed some of the early data of being able to pick up pre-disease, be it heart disease or cancer or other diseases, then we have to scan a lot more people, pick up the early disease and do something about it. And for that, you have to make it much, much cheaper, much, much easier. And that technology is on its way.
That slightly preempts the two further questions I've got here already. So the first of those was, how much more resolution is MRI likely to be able to give you? I mean, clearly the quality of what you showed us is pretty good, but is there more scope to get better quality, better definition MRI type images? Well,
absolutely. And actually, you can go right the other way. So one of the research programs we have at King's, at St. Thomas's, is actually ultra high field MRI. We have London's first 7 Tesla. So I was talking, the picture that I showed you today were from 1.5 and 3 Tesla scanners. Most scanners are 1.5 in the UK, but research places have some 3 Tesla scanners. But, and then when I was saying the low field ones were with half a Tesla. Well, you can go right the other way to 7 Tesla, and we have the first of these, which is right in the middle of the heart of a hospital for using clinical patients, including children in. And that can get you very high resolution imaging, because as the field strength goes up, the signal goes up, and the more signal you have, you can get to higher, better resolution. Now, there are very few of those scanners in the UK, only 5 or 6 of them, but they are mainly used by research groups to do the cutting edge. It's not for standard day-to-day clinical work, but when you can work out what, if you like, develop the technological advances, in those systems and then translate and move them back into the other more normal MR scanners. And again, by using AI, there's a real opportunity in being able to take those high resolutions and move them down into the lower field strength. But yeah, I mean, you know, with MR, you can get now sub-millimeter resolution, and I think you could go to quite a bit lower than that as well, using these new high field systems.
And then the final question I've got in advance before I turn to our audience. You spoke about the industry and the importance to the NHS of this type of technology, and you mentioned Siemens and Philips. Can you give a sort of indication of how much these scanners are and how widespread they are in the NHS?
Well, I mean, it's interesting. The UK has been at the bottom of the league tables in terms of having MRI and CT scanners compared to many of our peers like in Europe or in the US, Canada. But the government have realized that, and now they're realizing that they need to invest. And there's been recently a couple of waves, or just now actually we're in the middle of a wave of investment in getting more of these systems into hospitals and actually hopefully outside hospitals as well, because I think we need to get them you know, into the community too. So I suppose I can't give you exact numbers of how many there are. It depends on which hospital you're at. You know, at St. Thomas's, we have 7 of these just in our research group, and all different types and sizes. And there's another couple in the hospital. And then there's a few, you know, 4 or 5 of them at Guy's. So I know from our local hospitals, there's plenty, you might say. But many district hospitals will just have 1. And they're covering a big area as well, you see. And so there is a sense that we need to get this technology cheaper, simpler to use. I mean, one thing I didn't mention is at the moment it's quite complex to use. You need to be a real expert to run them. And some of the things that we're working on, again, using artificial intelligence, is can we make them push button? Make them very simple to use, so that you don't have to be a real expert to use them. And that allows them, again, to be much more widely used and reduce the cost as well. So there is progress being made, and I think that's the government are doing the right thing, investing in them, because that's how we'll improve our cancer outcomes and our cardiac outcomes, is by investing in advanced imaging.
Thank you.
Michael, there is a question which Dr. Johnson has been trying to ask. Would you like to read it out?
I will do. I was going to come to the questions through chat. Thank you, Afsat, and then I'll come back to you once we've gone through those. So thank you for pointing those out. So just in order of receipt, Dr. Alan Hodgson, who's president of the Royal Photographic Society, is asking a question. He says that there is a huge amount of 3D imaging data generated here. Will this be appropriate for 3D display by augmented reality headsets?
Absolutely. Now, that's a great question. And in fact, we have some research programs in that area. I didn't talk to you about them today. And it's just not just only from MRI, but you can also do this with ultrasound. And so it helps the surgeons to be able to see that. And we have a really good program on that allows you to sort of in 3D work out where the problem is and really look at if you're inside the heart. I mean, maybe in a future presentation, I can show some of that. But the other thing we're doing with augmented reality, which is really interesting, and again, my colleague, Professor Joe Haenel's doing this work, is you can actually provide that to the person inside the MR scanner, particularly if you're a child. Can you imagine if you have to anesthetize them? Well, that's quite difficult, or somebody who's older and maybe less able to hold still. We put them in an augmented reality world where they can play games and watch movies and control everything with their eyes. Just the movement of their eyes, we track them, gets them to be able to go places and do things. We can even actually get them to guide them to do like breathing that we want using that. It's amazing, actually. So augmented reality to look at the 3D data, but also to help the patients be relaxed and do what we want inside the scanners, particularly the children.
Thank you. And Lynette is asking about an older technology. She's asking, is stereoscopic viewing of 3D images useful to you?
That's great. You know, when I first started setting up the program, first at Guy's and then moved on to St. Thomas's, but at the same time, I set up an MR program in congenital heart disease in Great Ormond Street. And I remember, I mean, they didn't have one then. At first, they used to send all their patients to me at Guy's, and then we were overwhelmed. So I thought, well, I'll set a program for you there. So I turned up and I saw their scanner. It took a long time to set up the program there. But one of the things they did have at the time was exactly that. So you used to put these 3D glasses on and look at a screen and be able to see it. And this is a long time ago. This is now going back in 2003, 4. And yet, it never caught on. So it's interesting. But there was a system, there was a company making it, and I would try it on and put it on, but it never caught on.
From what it sounds like it's been overtaken by the AI. Our next question then is from Koshi Johnson, and I'm going to try pronouncing some of these words. So in asymptomatic diabetics, would ACE inhibitors help with the diastolic dysfunction picked up by MRI, i.e. would it be feasible that, like statins, any appropriate medication would be prescribed as a routine for diabetics, barring lifestyle changes and addressing risk factors?
Well, that's a great question. And I suppose up to now, we wouldn't really have been able to answer it. But now that we have the technology to be able to see that pre-symptomatic change, of course, the next step would be to see, look at, ACE inhibitors might be the drug, but there might be others. Actually, diabetes, there's been a wealth of new drugs that have come which work around glucose uptake in the cells and glucose metabolism. Maybe one of those drugs might be that you would normally not give, perhaps, but you might say, well, actually, it might be worth giving it, or a cardiovascular drug like an ACE inhibitor. There are many others. We could start thinking about studies to look at those and being able to see the effect, because now we have a way of being able to see these small effects, these early changes. So it's a great question. And yes, I don't think we can do that without doing those trials and studies to see.
Okay, so we have 3 final questions, and then I'll hand back to our host this evening, Dr. Afzal Ansari. Brian Stubbs is asking, do you see it being possible in the near future to be able to use AI and scanning technology to scan young athletes for potentially life-threatening undiscovered heart disease?
Absolutely. And of course, in many countries like Italy is a great example, many athletes do get either an ECG and sometimes a scan. And in fact, again, it's a thing I didn't get to talk to today, but one of our other programs, and Bram, who is one of our really bright young cardiology researchers working on the AI stuff, he also has led a program on exercise inside the MR scanner. We actually get athletes, normal people, patients with congenital heart disease, and now patients with heart failure and venous problems, etc., to go inside the MR scanner, and we get them to exercise on a bike really fast. And it's interesting, of course, because people move, or we can correct for all of that now using this technology. We can see what happens to the heart during strenuous exercise. And it's very interesting. We've recently published a number of papers in that to be able to understand how the heart works. And of course, absolutely, these scanning technologies can very much be applied. You don't need MRI, probably just ultrasound. An echocardiogram would be enough to screen athletes for the one we will really worry about, which is hypertrophic cardiomyopathy, HOCM.
Okay, and Alan Carr is asking, could MRI replace X-rays in angiograms, thereby reducing radiation exposure?
That's again a great question. And one of our programs, again, I'm talk about it today, is around ischemic heart disease, which is where you do angiograms. To be honest, these days we use a lot of CT, cardiac, CT, which uses X-rays, but perhaps a little bit lower dose because the technology has come down to be able to see those blood vessels of the heart, the coronary arteries, and that's very good. But what we found is, and where MRI really comes to its own, is just the narrowing in a blood vessel isn't enough. And MRI absolutely can now, I have a colleague called René Bottner who's doing some amazing work on being able to see these coronary arteries, the blood vessels of the heart, by MRI. And you can see them, but not only that, you can see the plaque in the narrowed areas. But where MRI has absolutely come to its own, and now it's basically the best test probably for this, is to see how important that narrowing is. So basically how much ischemia it causes. So we use the perfusion method that we use. And again, that is a great way of, that's when you need to intervene, because it's not just about there being a narrowing, but it needs to be a narrowing that causes a problem. And you can do that test by MRI. absolutely instead of a cardiac catheterization. And in fact, many studies, including one we were involved in recently published in New England Journal of Medicine, saying that that's a fantastic way of doing it.
Thank you. And we got a live question, I think, now. So, Abraham, I'm just going to unmute you, and you should be able to ask your question in person. If Zoom will let me unmute you.
He is asking questions all the way from Cape Town.
I think Zoom's not letting me unmute. Okay, Ibrahim, you should be able to speak now. You've gone.
His mic is not activated.
Yeah. Okay, you can be able to speak now. Thank you.
Can you hear me now?
Yes, we can.
Oh, thank you.
If we can. Hello.
I'd just like to ask Professor Razavi, you know, the technology that he has shown us this evening produces a 3D computer model of unborn babies' hearts from different angles. I would just like to ask a question about the MRI scan as to how many images are recorded inside the womb.
Yeah, sure. I mean, the way that technology works is that actually we do multiple number of slices in multiple directions, again, over and over again, 6 times, 8 times, so there are hundreds and hundreds of slices. And the clever bit of the technology is how it can bring them all together and twist and move them so that they're all aligned. That's the really clever bit. So there are hundreds and hundreds of, if you like, slices all combined to produce those beautiful 3D images.
Thank you.
Thank you. And then our final question this evening is really a comment from John Smith. And John's saying, thank you for a superb, fascinating talk. You've answered questions I may have had. It is wonderful to hear MRI is likely to become cheaper, smaller, and more widely available. So I think that's a sign of thanks from John. Thank you, John, for that. Afzal, I'd like to hand back to you now to close this evening. And you're unmuted. You should be unmuted.
Thank you, Michael. And well done. It was excellent that you pronounced all the medical terminology very correctly. Sorry, Michael, have you unmuted me?
Yes,
Yes, you're unmuted. We can hear you.
Sorry. Thank you. Right. Thank you. Well, all I need to do is have a few thank yous to various people. First and foremost is, of course, our speaker, Professor Razavi. Professor Razavi, thank you for an excellent lecture, which was informative, educational, and showing innovative and original research and demonstrating excellent use of imaging in medicine. And this is what this award is about, and was presented with great clarity. The majority of our students, the majority of our members, and when I say majority, I mean the big majority, they don't take that kind of images. They take images which are really in the photographic domain. But it's very interesting to see how it expands into using optical and non-optical devices to get images for diagnostics. Ladies and gentlemen, in fact, this is an excellent example of how to use imaging technologies that can be pushed its limit in medicine and surgery for the benefit of patients in the areas of public patient care, diagnostic, research, and treatment, and of course, to support training and higher medical education. At times, the recipients of the information are not fully aware as to how much time, effort, expertise goes into research projects, which in turn, besides time and expertise, also need lots of funding, which Professor Razavi has excelled at raising, and of course, in training his staff and research team, which is paramount for the completion of any research project. To be honest, there's nothing like completion of research project. It's always an ongoing, and there's more funding and more funding and more funding. And Professor Razavi, I wish you well in that area. Professor Razavi, please accept sincere gratitude on behalf of the Royal Photographic Society and the Royal College's Medal Award Committee, the audience, and indeed on my own behalf. Thank you very much. And ladies and gentlemen, if I don't see you virtually or in reality or otherwise, may I wish you Merry Christmas and Happy New Year, and may the next year be pandemic-free. Good night.
Thank you very much, everyone. Thank you.
Please show your appreciation.
Lovely.
Thank you.
Thank you.